Today we'll discuss about approach of pallor. A patient can get admitted in an ICU situation with pallor. You can see a patient in an outpatient or a ward with pallor. The situations can be a short duration, pallor noticed recently. Another situation is patient was having this pallor for months or years together. First, we will take the situation of a pale child in an intensive care unit. Two situations. One, surgical, a trauma, a bleed somewhere, significant bleed leading on to pale shock. The other situation, an anemic child going in for a congestive failure, significant distress. We can get admitted there. Third situation, and pallor is part of another underlying problem, just like malignancy, where the admission is basically for the underlying condition. So we'll be considering an OP situation where you see a patient with pallor. First thing, how will you look for pallor in a clinical scenario? All of us are aware of the conjunctival method, and other thing, you will be looking for palms and soles, then other sides, nails, lips and mucosa. These are all areas which we routinely look for to assess the pallor. Most important thing is conjunctiva, traditional method of looking for the conjunctiva. One very important thing, always look for both eyes together. Ask him to look up so that you are assessing the palpebral conjunctiva. So what are the false positive, false negative situations or the limitation of this method? One limitation is when you see a child who is very likely to be crying. So immediately after crying, you may get a congested palpebra conjunctiva. Then we are very likely to miss a true pallor state because conjunctiva looks red. What about the limitation of the palmar and plantar? Palms, of course, good, but if you are coming immediately after a cold situation, imagine you are coming from a rain, all your palms will be pale. So the vasoconstriction adds to the pallor situation. It doesn't represent the true hemoglobin situation. That doesn't reflect the anemic state, hemoglobin state. So you're attributing, there's a false positive situation here about the conjunctiva. It's a false negative situation. Here you are missing a pallor, here getting a pallor where the patient is not pale. Anyway, don't jump to the conclusion of an anemia from the pallor without looking multiple sides. Utilize this side, other. Totally, then only you come to the conclusion that this pallor may be representing the true anemic states. Then one very important point is picking out pallor where this can be mistaken by the other thing. One thing is fair complexion. You may consider a person pale. Actually, it's not pale. So don't go by the complexion, check the palpebral conjunctiva, all the other methods. Second thing, a dark complexion person, you may find it difficult to, you are likely to miss. So it's always a talent you should develop to pick a pallor in a dark person. Okay, that's all about the method. How will you evaluate a case of pallor? So before that, you need to have some theoretical knowledge. What are the basic reasons for an anemic situation, low hemoglobin situation? Of course, basically two situations. One, there is no production or less production. The other side, destruction or loss. Lysis or loss The other thing is decreased synthesis. In fact, a chronic small losses are also included in the inadequate production, because that lead to decreased supply of the nutrients and raw materials needed for the production. So decreased production, increased distraction. There are situations when both of this contributes. Examples are there, I'll come to that. So how will you decide a patient pallor is due to this group or this group? So first easiest thing is to utilize the clinical findings to rule out the possibility of hemolytic anemia, lytic situation. Then if there are no points to support the lysis, you go for the other. That's a better method. And then only you can utilize the history points. So it's the other way around. You are starting from the examination and you are going back to the history after that. That's one method. So here a child is seen to be pale. Then what you are looking for is it a lytic problem? If no, you go to the other group. So what are the points by which you can say you must be having a lysis? That depends upon the duration of the lysis. So no physical findings 100% argue that it is lysis. And you may miss a lytic process because there can be a situation where the positive findings may not be there. The classical hallmark of a lysis are three triads: pallor, jaundice and splenomegaly. Pallor, jaundice and splenomegaly. So here, if any of these things are there, more than one, it may not be always the three of the findings. A pale child with a spleen, that's enough. You may be dealing with the lytic process. The jaundice need not be there, because when the liver is normal, when there is lysis and bilirubin load is there, the liver will deal with the excess bilirubin, and most of the cases of hemolytic anemia you see jaundice won't be there. So pallor spleen combination is a common as pallor spleen and jaundice. When the unusual situation of hyperhemolytic crisis or something, only you get a jaundice also. That's a triad. So what are the exception to this situation? One thing is this spleen may not be there. You may be getting just pallor, not even jaundice and no liver and spleen. That is classical of an acute fast progressing hemolytic situations. Autoimmune hemolytic anemia, where the antibody destroys. Drug or toxin leading to hemolytic anemia fast can destroy. Then some of the situations of HUS, there can be a fast progression of pallor, spleen need not be there. So this previously normal situation and acute hemolysis, spleen need not be there. Classical is the autoimmune hemolytic anemia. So when you are getting pallor, spleen, jaundice, you are most likely dealing with a case of hemolytic anemia. And you have learned about the limitations of the finding also. Then one more very important thing is the facies. When there is a hemolytic facies, chipmunk facies, you call it as, what does that argue for? Definite, it's a hemolytic anemia. And one more point, it's not a short duration, it must be there for years together. So 2 points, the hemolytic anemic facies is the hemolytic anemia of long duration. So absence of facies doesn't rule out, because if it's short duration hemolytic anemia, we won't get the facies. So we won't be discussing too much about this part. I would just discuss this thing because stepwise you are ruling out the possibility, and if it is negative you are going down, to the decreased production group. We have kept a few possibilities. Even at this clinical examination you are likely to miss and maybe you have to come back at the end of the other examination. Am I missing a case of hemolytic anemia after searching the other group? Because I said there are false negative situations. There also you are very likely to consider the decreased production group. When we talk about the decreased production group, basically what are the things which are needed for the hemopoiesis, RBC production? So you just consider a factory where this is the a factory should be intact. Then raw materials should be there. A factory, raw materials, and a plan and controllers. So, when you talk about this thing, you will be just talking. Iron deficiency anemia is the most common. But this way, the deficiency of materials, raw materials, iron is just one which is the commonest. There can be folic acid, there can be B12, there can be zinc, there can be copper, there can be other micronutrients which all are needed for the synthesis. So loss or lack of a raw material is one of the commonest reasons, and you include all of them together as a nutritional anemias. Then about the plan, this is so important because all of us know different conditions where the plan is the basic plan, genetic thing can go wrong. That's not applicable only for the decreased synthesis, for the lysis also. It's all genetically mediated, all the lytic group also. Here, there are certain things like Diamond-Blackfan syndrome, constitutional plastic anemia, all these things. If plan goes wrong, you can't synthesize. So there should be a plan, there should be a factory, there should be these raw materials, and last one, controllers. A heard of erythropoietin, a heard of hormones like thyroid, growth hormone, sex steroids. So there can be anemia situation due to hypothyroidism. A patient can present with anemia in a case of growth hormone deficiency. Erythropoietin is a classical thing, presentation in chronic renal failure. So the controllers. So we'll be coming to the rarer situation after rolling out the commoner situation. That's all. The incidence is 95% may be due to nutritional and out of which iron. But when you don't have points to argue for this thing, you go for the rarer and rarer, and then only you'll end up in the rarer situation of hypothyroidism presenting with anemia. About the factory, what can go wrong with the factory? The classical thing is factory is completely bomb blast. A plastic anemia factory one day just blasts off. Maybe by drug, maybe by immune process, maybe by an infection like hepatitis B. You have heard of Epstein-Barr viruses. You have got all these parvovirus, bone marrow suppression, aplasia. The other thing is bone marrow is invaded by classical thing is leukemia, retinoblastoma, neuroblastoma, all those sort of malignancies in a child and older person, again malignancy. Sometimes other infections can transiently suppress bone marrow, like heard of possibility of malaria, tuberculosis also, and leishmania also, and transiently suppress treatable entities. It's not like your parvovirus suppression, which will maybe irreversible situation. So when you consider the decreased production state, you should be considering all these possibilities. Then only comes the relevance of the history to differentiate different possibilities. Which all points in the history are helpful. Here, for the plan, you ask for the family history, construct a pedigree chart. So if there is any family history, maybe you are dealing with some of the genetic disorders, constitutional plastic anemia, Diamond-Blackfan syndrome, or dyserythropoietic anemia. I said dyserythropoietic anemia is something which produces both the features. Decreased production is there, lysis is there. So different groups of, it's not a single entity. Genetic, so pedigree chart you need to construct. And about the nutritional deficiency, lack of the raw materials, you need to go in depth about the deficiency. What about the intake? Whether he is getting weekly iron folic acid, whether deworming is done, what is his lifestyle, is walking with barefoot, use of toilets. All these things are simple things. What about the consumption of the iron containing diet, or the supplementations, programs of the Iron Plus National Program. So all these things are important to argue for or rule out the nutritional. That's a vast topic, because nutritional anemia can occur not only due to deficiency. There are the disease states also of the terminal ileum, the duodenum. So it's a different entity how to approach further when you land up with a definite problem of nutrient deficiency. Don't stop there. A little further you may have to move in certain situations. Okay. And about the other history, so nutritional history is the one thing which gives the answer. And about the controllers, you need to consider the possibility of a renal, other hormonal things, etc. etc. And of course here also the duration of anemia is important. If there is a long duration, consider the possibility of blood loss. The adult and the children, the same nutritional anemia are due to different things. Blood loss contributes maximum in an adult person. In a young child, real nutritional deficiency contributes to the reasons for the iron deficiency anemia. Okay, the rest of the history part, or depending upon the situation. What about the, how will you evaluate general examination? Of course, vital signs. Patient is dyspneic, congestive failure. That means it's an emergency, and your plan to transfuse should be taken considering all these things. A patient seems to be pale, is stable, better not to give transfusion. Transfuse only in case of symptomatic patient. Otherwise, better avoid. Blood transfusion should be avoided as far as possible unless it is that much indicated. So patient in congestive failure, be careful here. A patient in congestive failure, we are very likely to consider the possibility of anemia leading on to this thing. There can be a situation of a hemolytic anemia coming with congestive failure due to cardiomyopathy also. So be careful about not missing that. In the examination, how to differentiate between these groups? Of course, I said, is there any feature of hemolytic anemia, hemolysis, pallor, jaundice and spleen? Okay, it's a lytic process. The other situation, there is no jaundice, pallor, organomegaly, lymph nodes, liver, spleen, organomegaly. What does it argue? Most likely in this context, it must be bone marrow invasion, leukemia, lymphoma, or other malignancies. For presence of organomegaly, lymph node argues more for a malignancy. Hemolytic facies or hemolytic features, the other. Then, about the utilization of the abdomen, the presence and absence of spleen. How it will help you? The spleen may be absent. So just absence of spleen, can you say it's not hemolytic anemia? No. One very important entity is sickle cell anemia. Above 6 years, the patient is pale and is coming from an area where sickle cell anemia is common. Absence of spleen doesn't rule out the possibility. The other situation, autosplenectomy. The other situation is removal of the spleen. Splenectomy done. And maybe third one is a rapid hemolysis, acute situation. So, absence of spleen still being hemolytic anemia. About the other way, there is pallor, there is spleen. Can you be sure that it is a lytic process? No. Here again, it can be a decreased production group, out of which malignancy. So, maybe in the decreased production group, lymphoma, your leukemia, pallor, spleen can be there. So, don't jump to the conclusion that it's a hemolytic anemia just by saying pallor and spleen. So consider decreased production group malignancy is also here. So anyway, that be sorted out when you do the investigation part. So supportive evidence of leukemia always you should be looking for in the examination of the other bleeding manifestation, bone tenderness, everything. Okay, I won't be going too much about the investigations. I'll be considering the investigations of one group only now, nutrition anemia. But all things, simple hemoglobin, peripheral smear. These are the most important bedside thing. You should be doing it. Hemoglobin. When you interpret the hemoglobin, always consider the age, sex, and what is normal for that age. Don't jump to the conclusion that is pallor because somebody put it as a normal range is starting from 12 to 14. It's not. So in a child, the age and the normalcy based on the age should be considered. Peripheral smear is the most useful investigation. So check for lysis. You'll get evidence of lysis. What are the evidence of lysis? Increase in the number of youngsters. Who are the youngsters? Normoblasts and the reticulocyte. Will you get the reticulocyte count in the peripheral smear? No. But you will get normoblasts and polychromasia. So if there is normoblasts and polychromasia, you are dealing with a case of lysis. And other clues about the RBC analysis. Is it microid? It's a anisopoikilocytosis, is it target cells, is it spirocytes? Lot of clues about from the RBC morphology. So, lytic group you will get some clue from the peripheral smear. You need more investigations in that line. Then peripheral smear will give importance, give the impression about the low count situation. WBCs are not seen, very low count. Platelets not seen, maybe dealing with the case of aplastic anemia. The other situation, abnormal cells are seen. Leukemia, AML, OLL, or different types of malignancy, hematological malignancies. So these are the two important investigations. Of course, based on, I forgot to mention about the notational one. You can get a hypochromic microcytic anemia, anisopoikilocytosis, and it will be helped by your reticulocyte, the indices of the RBC. All these things you need to read. Then macrocytes get in a case of B12 and folic acid deficiency. That can be the combination of dimorphic anemia. So all this information you get by simple bedside peripheral smear. Then other investigation, confirmatory, lot of them other, out of which ferritin is one very simple thing. So we will be going in depth about these sophisticated investigations. So we'll talk about the rest of the hemolytic anemia some other time. Thank you.